Hello, everybody. Good afternoon. This is Dr. Olivera. I'm a neurosurgeon, specialist in neurological surgery, which encompasses the surgery of the brain and the spine and the peripheral nerves. I'm currently the medical director of the USF Neurosurgery at AdventHealth Tampa, which is a group of neurosurgeons that are in charge of rendering all kinds of neurosurgical services to the population that comes to our hospital, either from all the referral centers that we have around the area, through the ER to the transfer center, or through our clinic. We're going to talk today about the newest technology we have available in the world of neurosurgery and how we can put this into the service of our patient population. Our presentation today is going to be about innovative visualization and navigation for neurosurgery. You can see all the information there, and what you see in that screen is basically the most important part of our technological advances over the last few years here in AdventHealth Tampa. The objective of our presentation talk today is that everybody that looks at this will be able to learn how the latest technological innovations in neurosurgery can benefit our patients, like I said previously. It's very important to understand the role of technology in neurosurgery. Everybody remembers the big leaps we did in the medical profession in the treatment of heart disease on the second half of the 20th century. It was when, heart transplants and bypasses and then coronary artery stenting, etc. We are now at that point in the neurosciences. We have learned in the cerebrovascular part of neurosurgery from all the experience accumulated by the heart surgeons and cardiologists in the past, but now we're advocating for a most comprehensive way of treating neurological diseases. And why is that? Because neurological diseases are much more dependent on technology than other specialties. And now is the right time. Now we have the tools that we did not have 20, 30, or 40 years ago to be able to do the things we do. One of the most important things is the augment of all the computerized imaging, the digital technology, and the information technology. This is paramount because we need to visualize pretty much all the structures in the brain that we cannot see normally, and that was not possible. Basically 20 years ago, we were at the beginning of MRI. 30, 40 years ago, we're at the beginning of CT scan, and the things that we have today are like science fiction, basically, when you compare it with the things we had in the past technology-wise. It's very important to understand that the use of this technology is mainly to try to improve the patient care, not only at the time of the surgery, but at the time of planning the surgery, setting up a good expectation, having a good diagnosis, and then having the right plan for the treatment of the patient. All right. So basically, we're presenting today what we call the Bright Matter Integrated Platform, which is the first time that robotics were brought into the realm of brain surgery. And it was done in a way that is integrative, in which you can see that it's not like the robot is going to do the surgery, like in other specialties. I get that question from patients all the time. Is a robot going to operate on my brain? And no, that is not what's going to happen. What's going to happen is the robot is going to make the surgery less invasive. It's going to make the surgery more specific. It's going to make the surgery sharper, neater, cleaner, more ergonomic, and more tailored to each specific patient. Why is that? Because now, like you can see, we have the experience of minimally invasive surgery. Now we have the possibility of not having to do what you see on the screen right now, in which, in order to amplify the image and have a good view of the patient's brain, we needed a bulky microscope that is usually in between the patient and the surgeon, having the surgeons, to get very tired with the hands up in the air and not being able to do precise movements because you have this machine in between you and the patient. And research showed that we used to spend a lot of time trying to focus and trying to visualize the brain the right way to be able to perform the procedures, and that ergonomically our surgeons were exhausting, and we end up suffering from all kinds of degenerative disease and job-related problems due to the lack of a good platform to perform the surgeries in a comfortable and ergonomic way. This is where this technology comes into play. And what you can see here is the integration of all the parts of this system. You have the robot on the right. It's called Modus V, which is nothing but a robotic arm. The robot basically follows our instructions, our guidance, and has a very precise and powerful optical system. It's like an exoscope, the way it is qualified, that will obtain a quality of imaging and amplification that is unheard of. But on top of that, it also has the navigation system, the Bright Matter Guide, which is what is going to allow us to orient, synchronize the patient's brain with the imaging that we have, and is going to guide us through the robot. So it integrates seamlessly and allow the surgeon to know exactly where you are at any time in the patient's brain, and have the robot to follow your instructions, so you do not even have to touch it at all. Then you have the acquisition of imaging that is done through any standard scanner, but then when you process that data and you acquired that information and put it into the system, that's when the magic happens, because it's actually for the surgical planning part of it, where all this information in the data hub gets processed automatically, without having a technician to perform it. It's a brand new way of doing this kind of processing. You can see on the screen, so we're going to go into a little bit more detail later on how the fibers inside of your brain can get mapped out in an incredible, accurate, and beautiful way that was not possible before. In the past, when we tried to do this processing with other technologies, it required a very labor-intensive process with the technicians, and sometimes the images were not good enough to do surgery based on them, or they were not even good enough to have a buildup of these fibers. By that time, the patient was already in the OR. You could not repeat the scan, and it was not efficient enough. Now, the process actually tells you if the images are good enough or not for this, and if it is not, then the images are acquired again when the patient's still on the scanner table and we don't have to wait for the processing. So it's very streamlined, very efficient, with an unsurpassed quality. And this is the most important part of this technology, which is the tractography that we have, or DTI. It stands for Diffusion Imaging. It's a specific way of acquiring information from an MR scanner. MRI stands for magnetic resonance imaging, which is nothing but the way a magnet acquires the charge of the electrons and the molecules, especially the molecules of water inside of the brain, as they move and rotate when the magnetic field alternates. That is what gives the MR scanner that accuracy, that beautiful quality of imaging. And it's used specifically in this sequence to follow the nerve fibers. If you can see there, they're color coded. This could be taken to an amazing degree of sharpness and detail that in this image, which is a rough depiction of it, you can see there are basically three kinds of fibers. They have the blue fibers, you have the red fibers, and you have the green fibers. The blue fibers, which you can say, well, are the ones that go up and down. You know, a good way to remember this is when you think about the sky is blue, so when you look up, those are the fibers. And you can see on the top left image, the coronal views, how you have the fibers coming, in this case, from the cortex all the way down into the brainstem and then into the spinal cord below the foramen magnum. Those are the ascending and descending fibers, and mostly sensory and motor information. If you look at the bottom right, then you can see how they spread out from the front of the head to the back. It's called the corona radiata, and this is the area that gets affected when you have strokes and give the patient the paralysis in one side of the body or the other. And going back to the imaging on the left, top and bottom both, you can see that big red fiber bundle in the center of the brain. That's called the corpus callosum. And this is the main way the left hemisphere communicates with the right hemisphere. That's how your two brains talk to each other and you become a complete person. And when you have patients that have intractable epilepsy and other diseases, sometimes you have to go through it, or you have to purposely cut that communication so seizures do not spread from one side of the brain to the other. It's called a corpus callosotomy. And when you do that, patients suffer what we call a disconnection syndrome, because at that point, your right hemisphere really doesn't know what the left hemisphere is doing, and it's like they're two different persons doing two different things at the same time with no communication. You can see it on the bottom left, from the bottom up, as they really cross from one side to the other. And then you have the green fibers. The green fibers are the one that go from the front to the back of the head, as you can tell on the bottom pictures, both on the left and the right. Those green fibers communicate the different lobes of the same hemisphere. They do not cross the midline, but they communicate your frontal lobe with your parietal lobe, with your occipital lobes, and they come around and communicate your temporal lobes, and then communicate your temporal lobes with your frontal lobes, so you can hear, understand language, and at the same time generate language in many ways. So they're very important. A good way to remember those, if you look at the bottom left picture, green light allows you to go move forward, backward. The red light is your stop. So the green fibers go from the front to the back of the head, the red fibers side to side, kind of like crossing them, and the blue fibers are the ones that go to the sky. This is a good way to remember how these fibers run, although you cannot see the red fibers there. I like the system. That quote on the screen is from myself, and just because I like it. And it's just that this technology is not only becoming the new standard of care, but opens a whole new window into the future of neurosurgery as a whole. Because I do certainly believe that this way of looking at the brain is changing the way we do neurosurgery as a whole. What are the benefits of this for the patient? If you look at this image, you can, in a nutshell, understand how important this is for the development of minimally invasive neurosurgery. If you see in the image, the bottom of the fibers, you have fibers that are kind of like wrapped around a orange mass. So that is a brain tumor. And on top of the brain tumor, you have superimposed kind of like the image of a tube that has this axis inside of it. That is what we do to plan the surgeries. That's what this technology does to help us take care of patients. Now you have exactly where the tumor is, you know exactly the fibers that are wrapping around that tumor, and you choose a minimally invasive approach to it. You don't have to do a big opening and a big brain surgery to take the tumor out, because now you kind of like precisely go where the tumor is, and you can angle it, and you can plan your trajectory to avoid going across or damaging those fibers that are close by to the tumor or around it, and that way you avoid damage to the patient's functions that depend on those fibers. That is done even before you do the surgery. By the time the patient's in the OR, now you have a plan, and you position the patient accordingly, and when you synchronize the patient's head with the computer program, then it's like a GPS, basically. It guides you and tells you where you are at any time during the surgery. This is more or less what I explained about the diffusion imaging, in which you can see how the different fibers are depicted on a picture and how it's done automatically. So that way you don't have to delay the surgery, you don't have to rescan the patient. It just goes from the scanner into your station, and you're ready to go to do the surgery that the patient needs. This is another way of seeing all the images at one specific point in space. Then you can actually reduce those tracks to the ones that you really need, or the ones that only intersect, or you would intersect on your trajectory. That way you don't have to worry about the rest of the fibers, so you don't get confused with all this information, and then you just know which are the ones that are on your way that you need to avoid to not to damage the patient. This is another picture, and when you see that specific tract that I talked to you about that goes around, is the only one that goes from temporal around the sylvian fissure into the frontal, and that is the very important part of the brain, because it's what communicates your understanding of language with your ability to express language. This is another way of looking at those fibers that go from your motor cortex. Knowing where these fibers are, that's how you avoid paralysis. If you have a tumor that is very close to these areas, instead of going right on it, because you will know at that point you will give the patient a paralysis in the other side of the body, then you can go from the front, you can go from the back, kind of like rearrange your trajectory so you don't damage the patient. This is the same thing, but just looking at it in a different perspective. And then this is how you then put this together in the OR with the navigation to calculate your trajectory and to know where you're going to go through without having to damage any areas of the brain that don't need to be damaged. Incorporating not only the tractography, but then your surgical tools. This system allows you to then get alignment on your trajectory and even calculate the size of the craniotomy that you need to do to approach the lesion without minimal damage. The other part that is very important is the quality of the image. This is a fully optical system that allows you to have even more magnification than the traditional microscope. The processing of the images is digital, but the acquisition is optical. So that gives a totally different quality to the visualization and the degree of detail that we can see the brain structures with. There also, this robot can keep in focus a big area that is not possible to do with any other equipment. So you have pretty much everything on your field on focus. And you, instead of being to constantly have to adjust when you move 1 millimeter deeper or more towards the surface and have to stop doing what you're doing to regulate the microscope. This is one of the images in which you can see how you find around the fibers, how you find that trajectory that's the safest to access the tumor without disturbing those fibers on the patient's brain. Like I said, this is actually a depiction of one of the brain tumors. There is a malignant brain tumor in which you traditionally will have a trajectory going through the shortest way to get to the brain lesion, thinking that that way you will be damaging less brain, as if the lesion is closer to the surface of the brain, then your traditional wisdom is let's just try to go through the area that is closest to the surface so you don't damage the brain in between. With this extra information now, sometimes we find that the lesions are not above the fibers but are below the fibers. That means you going through those fibers to get to the tumor will give the patient a deficit, and then you can rearrange and get a trajectory that even longer or more challenging surgically, that at least is safer for the patient. Same thing here, calculating the window of entry that can be done not only for tumors, but also for hematomas. When you have an intercerebral hemorrhage, you know that those patients will benefit from having the blood clot evacuated and reducing the pressure inside of the brain, which is sometimes or usually the cause of death on these patients. And you do not want to damage the surrounding areas more than before. In the past, this is you can see the preoperative and postoperative images there, in which calculating that trajectory with this technology allowed for the brain to return to its normal position with no interruption of the motor tracts, meaning the patient did not have a postoperative motor deficit, which in traditional surgery have been very, very likely, because if you look at the preoperative scan, you can see the hemorrhage is below, underneath the fibers, and you would probably transect those fibers on your way trying to get the tumor out. In summary, I think this is a very innovative and good way of understanding the brain anatomy, understanding the way the information goes through the brain and from there to and from the body, and with the ability to have that at the tip of your fingers, you can do very, very good things with the patients and trying to take care of them. On this video, you can actually see the quality of the imaging as you go in and out on the, with the exoscope. You can see the pulsating arteries. This is the carotid artery at the bottom of the skull base. and you are in focus at all times. In the real OR, you can do this. It doesn't advance on a by jumping. It's very smooth, and you can actually move the exoscope to the optimal angle without having any need to stop operating while it does, because that's where the robot becomes more and more helpful for us. In this case, you can see a brain tumor that has been taken out. This is how you will see the brain through that tunnel, that little tube, in which you can do minimally invasive brain surgery. So you can tell here how precise you can be with your movements and trying to uncover those nerves that are right next to the tumor. The instrument that's moving is separating that white structure there, that's a nerve, and underneath the left instrument, that's where the tumor is. And if you don't have this quality of visualization, you're not going to be able to do those kinds of movements with the precision required.
Well, new cutting-edge medical technology making its way to the Tampa Bay area.
Fox 13's Dr. Joe shows us tonight how technology from the International Space Station, saving lives here on Earth.
The day after Hurricane Irma struck, like most Floridians, Ken Lambert was outside picking up the pieces.
I was in my yard just cleaning up small limb debris, and I noticed a numbness in my right hand and a portion in my right face.
What he didn't know is that months before the monstrous storm made its way up the state, a very different kind of storm was silently brewing inside his skull.
When you get the diagnosis of a brain tumor, it'll bring you to your knees pretty quickly. In more ways than one.
To remove the cancer, Lambert became one of the first in the world to undergo surgery using the latest model of the Synaptive Modus 5. Its robotic arm is derived from technology used on the International Space Station. But instead of harboring tools to repair satellites, this movable arm contains a digital microscope.
With this new technology, we can have the best imaging, the best views, and actually the best way to operate on our patients in the brain, in the spine, in ways that we couldn't do before.
Florida Hospital neurosurgeon Dr. Raul Olivera maneuvers the robotic arm using a special wand. Within its Bright Matter software system, preloaded MRI images of nerve tracts in the brain can be accessed in real time, allowing surgeons to navigate around critical structures while operating on the brain.
Overall, it's going to improve all kinds of cases: tumors, vascular malformations, strokes, or even traumatic injuries.
The enhanced precision may lead to a faster recovery.
I was able to do the Gator Chomp, which was my alma mater, and watch the national championship football game within 2.5 hours of surgery that night.
4 days after the procedure, Lambert was back to work. You can see in this post-operative CAT scan, the dark area is where the tumor used to be. And while he's happy with his outcome, Olivera says this is just the beginning.
It's not what it brings now only. It's what it holds for the future that it has me more excited than anything.
For the Fox Medical Team, I'm Dr. Joette Giovinco.
Well, Dr. Joe also says the technology is helping people with epilepsy, breast cancer, and spinal tumors.
Well, in this case, I think that, and I hope that I was able to explain to you guys the importance of this new technology and how we can use it for us to take care of our patients. I believe that understanding the importance of the brain anatomy and the location of these lesions, as well as the relationship of the blood clots or the tumors with the brain fibers, can allow us to take care of our patients in a more efficient and perfect way. Thank you very much, and I hope that you can learn something from us in this talk, and looking forward to continue giving information about neurosurgery for you.